I don't know if I will convince you, because I am not convinced too about the operation. But first of all, I want to thank all my friends that invite me for the first time to visit Israel as a special country. And I am a little bit worried about the weather, because tomorrow I should go to the Dead Sea. But and yesterday I risked to finish to the intensive care after a tour at the Jerusalem. But anyway, thanks to Alon and to Hahir, and I saw one of my best friends is Petaki Rezman, and thanks to Joel again for the words that you gave to me, the opportunity to be in this lecture. Please, we go to the pilonidal sinus is a common disease that affects young males with an important economic impact. As Dr. Eden said, a number of surgical options exist, but there is no gold standard surgical treatment. The ideal treatment should be very simple, with a low recurrence rate, short hospital stay, no wound care, and rapid return to work. But there is no still a gold standard. The major problems concerning the disease are the recurrence rate and the aesthetic results. At the moment, our treatment strategy is a tension-free primary closure and a Limberg flap with a rotation lamp. Why tension-free primary closure? Why? Because it's a simple and effective. Needs a short hospital stay, few hours in the hospital, reduced pain, limited wound care, and a rapid return to the activity. This is our operation with a tension-free primary closure, with patients in a prone position, buttocks retracted, the pathologic area mapped on the skin, and an excision, a skin elliptic incision with excision of the sinus through the presacral fascia. And then the cavity will be closed with a double interrupted stitch, resorbable stitch, deeper layer included deep half of the submucosal tissue and the presacral fascia to reduce the tension, and a superficial layer to include the external half of the submucosal tissue and the derma. At the end of the procedure, we put a Gendaflix with a sponge into the cavity in every patient, avoiding any drains. This is Gendaflix, is complete reabsorption, and release zentamicin and helps for the hemostasis. This is the end of the procedure with the skin closure with a 3-O resorbable or liquid skin adhesive. But now just want to show the video, a short video with local anesthesia. We just injected the sinus, the excision of the sinus. The problem of this operation is the wound will be in the middle of the cleft, and this is very bad for the recurrence rate. This is the first stitch. We included the presacral fascia, and just we used 2-hole Vicryl, and there is other stitch. Just we not included the presacral fascia. There are 3 stitches very deep, and the other 2 or 3 superficial. This is when we finish, and then we put the Gendaflix into the cavity we don't leave any drainage into the cavity, and we close The problem with this operation is just because the wound will be in the midline, and this is a reason of the high incidence of recurrence. This is the end of the procedure. The recurrence on the literature is varies from 7 to 42% for primary closure, while 0 to 3% after limber flap reported by this Turkish study on British Journal of Surgery. The indication for limber flap is my preferred operation, is a treatment of choice in all cases of chronic and or recurrent pilonidal disease, because it flattens the natal cleft, avoid dead space, and has a good blood supply, because when the scar is just not in the midline, the recurrence rate will be less than other operation. The rhomboid incision included sinus and its extension to the presacral fascia, and the flap is constructed extending the lateral and down to the gluteal fascia, and then the flap will be transposed. This is an old video where the excision of the flap, we included all the subcutaneous until the fascia. This is the flap was prepared, included the subcutaneous and until the gluteal fascia, and then we give 3 stitches just to reconstruction and to transpose the flap. It's very important the tip of the flap, because you have to be careful, otherwise it will be necrotic, and it will be a complication of this procedure. So we try to give the stitch just and the subcutaneous, not include the skin. In the last time we try to avoid this acute angle, just to reduce the incidence of necrosis at the top of the flap. It's very important that the hemostasis should be accurate, and we leave a drainage for the first 24 hours. This is at the end of the procedure of the transposition of the flap. This is our study is a prospective randomized study comparing limber flap versus tension-free primary closure. Included 2 groups of patients, 130 patients each group, no difference in terms of gender, age. And as you can see, the primary closure was performed in 22% of the cases with acute infection compared to 20%. For the chronic infection, 85% of the patients had a limber flap, concerning the anesthesia, all the primary closure was under local anesthesia, and only 50% of the limber flap had the local anesthesia. Only the first the genderflex positioned in the wound, and duration of operation was quite different in two kind of operation. In terms of success, we can see no difference were seen between the 2 group of patients, and the difference was in terms of hospital stay, 8 hours for the primary closure, 4 days for the limber flap. So as for recovery was 7 in the primary closure compared to 4.9 in limbar flap. Difference was seen in terms of pain in two group of patients with less pain in the tension-free. This what's happened in the clinical results. We can see the difference of in terms of the wound distance was no difference, but the hood infection was higher in the primary closure compared to the limbar flap, and the relapse 3.8% compared to 0.8 in the limbar flap. Some paper reported on the literature with the tension-free closure. You can see the relapse it varies from 1.9 to 11% with a descent of the suture from 1 to 6.4% in the other study. This is a paper reported by Mendes where the management of opilonidal sinus with oblique excision and the primary closure results of 40, almost 500 patients that to avoid the wound on the midline of the anal cleft, and with a follow-up up to 3, 6, 12, and 18 months with a mean hospital stays 5 days, and the recurrence rate was 5.6 at 18 months. What about the literature reported after limbar flap? You can see that the relapse is lower than the other procedure, from 0 to 3.5, and the descent was in 13% in this paper reported by Rungan. Chian is another study that he tried to give a modified limbar flap with asymmetric incision, and he reported the results are improved in this paper with no statistical difference in terms of recurrence. But he concluded that after 160 patients with a modified limbar flap that is superior in terms of infection, mobilization time, discharge from hospital, time of work, and a low recurrence rate with this modified technique. These are the two trials comparing limbar flap versus primary closure, and they concluded that limbar flap is superior in terms of pain, complication, healing time, and the recurrence rate comparing 0 versus 11%. In this paper published a few years ago. Our conclusions are that both methods show effective clinical results with some advantages and some limitations. The first one is quite difficult because the problems are the traction or the tension of the suture in the middle anal cleft, but the clinical success depends on the presence of acute infection at the time of surgery. But our policy at the moment is tension-free primary closure when there are acute infection, limbar flap in chronic extensive recurrent disease. Thank you for the attention.